So, dear colleagues, ladies and gentlemen, I want to say welcome to you to this, the only debate in this Congress. It's a both pleasure and privilege for me to be chairing this session. This is a very special session. My name is Meral Kayıkçıoğlu, and our question today is lowering LDL, a solved problem. And as you know, this is a very important topic, evolving topic in the cardiovascular medicine. We have two experts in the lipid area, and both of them are globally recognized leaders in atherosclerosis and prevention. On one side, we have Professor Børge Nordesgaard. He's the current president, as you know, of the EAS, and he is pros in this debate. And then we have on the other side, we have Professor Kosh Ray. He is the immediate past president of EAS, and he is the con. So, floor is yours.
Thank you, Meryl. So, it's been a long day, and you don't need a lot of slides, but perhaps you need a little bit of humor. So I was asked to talk about LDL lowering is not a solved problem and why we need to keep working at it. But before I do that, we need to basically look at this format and who I'm up against. You know, the man's a demigod, EAS president, Anitskov Prize winner, and he comes from Scandinavia. So if you look, you'll see my opponent. This is Borg in his younger days. You can see the long hair. You can see that when he was younger, at least, he was known for his enormous hammer. And then you can basically see that as time has passed and he's matured, he's become like Odin. As you can see, they're complete with eye patch. But actually, when he asked me to go first, and they said, would I give him some pictures, etc., I thought, you're actually more like Loki. Now, Borg loves a problem. He's got a beautiful house, beautiful country, beautiful family, but he always seeks problems, new founders. This is him thinking about a new journey. And he gets so excited when he goes on that journey to actually try and solve a problem that doesn't exist. And then when he actually goes to these beautiful places, what is it with you and these phallic symbols? And there's like this, he gave them to me. And so this is his latest exploration. You see, this is a landing party. I think this was 6th of January, Washington, D.C. I think that photo, I've seen that somewhere before, in North America, perhaps. But somewhere in his explorations, something went wrong. Whilst looking at nature, he drank the Kool-Aid. And as a result of that, it affected his mind. And now, look at him. He thinks he's Tarzan. It's a bit doped out in that. But what was in that? I need some of that. And he's going to try and convince you to believe that LDL lowering is a done deal. It's dead. We should move on to other things. But what you've got to remember is, despite the H-index, despite everything that he's got, he comes from an important and interesting country. Anybody know who this person is? Hans Christian Andersen. And what was he famous for? Fairy tales. So just remember that when you listen to what he's going to say. So, is it a done deal? Treatments for LDL lowering should be safe, effective, cheap, acceptable to the population, well tolerated, and our patients should be able to adhere to the treatment regimen, and it should be easy to implement in healthcare systems. That's the problem. That is the real question. Are we doing that? That's your bar. So here's the issue that we've got. We don't treat LDL for the sake of it. We basically are using it as a means to reduce atherosclerotic cardiovascular disease. And with 8 billion people on the planet, and at different stages of this process, we simply do not put all of those things I've shown you into place to solve the solution that is LDL lowering towards this disease process. By the time we think about that stepwise approach and monotherapy, most of our patients will require multiple medications because they're to the right of that line. where they've got much, much more plaque. You'll say to me, but what about all these other treatments that we've been hearing about? What about ezetimibe, reducing absorption of cholesterol from the liver, bempedoic acid, statins, inclisiran, monoclonal antibodies? We can use these in combination. Well, they all work through the LDL receptor. They increase either the upregulation of the LDL receptor or the survival of the LDL receptor. But the first-line treatment is always going to be a statin. And you can see here the impact of anything that has to be taken daily. On the left-hand side, you can see that even when the doctors do the right things, if the patients don't actually take the medications properly, you're only getting about a 10% risk reduction, yet you're writing your scripts. Patients, this was some of the work we did years ago, looking at new onset diabetes in a dose-dependent fashion, and then we found it was an on-target effect. Patients are worried about this. The world is getting more obese. These are people going to be more prone to diabetes. And then even when we actually take our prescribed medications, many of these patients will permanently discontinue, about 30% at 1 year. These are the first-line treatments. These are the cheapest treatments. We know they work, but there are reasons that our patients are not going to take them. The EAS thought it was important enough to write a consensus paper on this, statin-associated muscle symptoms, and how to address this, and how to manage this. And we know that now, with the guidelines moving to lower and lower targets, this is simply beyond the realms of monotherapy. And if you look at even when you have perfect, high-intensity statin therapy, physically changing the goalpost from 1.8 to 1.4 millimoles per liter means now, instead of 45% of patients at goal, perfect treatment adherence, 22% will be at goal. When you add in a second drug, ezetimibe, cheap, generic, only another 20% will get to goal. What about the other 60? So is it a solved problem? And you'd say, well, that was done before the 2019 guidelines. What about afterwards? And yes, although we saw in Da Vinci 9% use of ezetimibe as combination therapy, and that increased in Santorini, goal attainment was only still 30%, even though we've increased the potency or the use of that fourfold. What about add-on therapies? There are problems. They are good, they're effective, but it's the way we incorporate them. Bempedoic acid, very good, but 18% reduction. And in many countries like mine, it's used in statin-intolerant patients. What does that mean? You start further away from goal. So can I get there with just that alone? The PCSK9 monoclonals, fantastic treatments, but cost and accessibility has limited their use. In my country, the cheapest in the world for inclisiran, we should have had 300,000 patients. We've only got 27,000 patients now on this, largely because of it being underutilized in primary care. What about those people who do not have LDL receptor function at all? Is it really a solved thing? This is basically the HIC registry data, looking at homozygous FH. Look at the number of medications you're going to have to use to even get your patients to below 5 millimoles per liter. And then if you look at survival curves on the right-hand side, even those with the lowest tertile of LDL range from 4.9 to 12.5, the lowest, look at their survival. So, to summarize, LDL lowering is not a solved problem. The global scale of ASCVD makes it so. The acceptability and tolerability of cheap medications like statins make it so. The effectiveness of current oral therapies make it so. The ability of patients to adhere to complex regimens make it so. And the need for multiple combination therapies make it so. And finally, the complexity of our healthcare systems make it so. So I have one request for you, that when you basically listen politely to my esteemed colleague, realize that he and his two friends, that no doubt he will talk about, LPA and remnant cholesterol, accompanying him on this Viking longship, are on their way to Neverland. Thank you for listening.
So thank you.
Well, yeah, Cos knew, of course, exactly what I'll talk about, but there we are. But, I knew also what you would talk about. Oh, you talk about all these drugs routes. So, Cos, he likes the life, so the more drugs he talks about, I mean, then he'll make money and he can have this fantastic lifestyle. I mean, I understand that, Cos. It's all right. So, I don't know, I tried to explain this to you before. It's a paper I wrote back in 2016. Obviously, you haven't really noticed it much, right? What I put on the y-axis is what's the clinical focus on lipoprotein for cardiovascular disease prevention, and on the x-axis is years. And you can see by now, 2025, it's like everybody in clinics, they look at LDL cholesterol. So, I mean, you guys have been completely brainwashed about it. And then there's the HDL that went up and went down, and it is actually the one below you can see. It's the remnant cholesterol, triglycerides, and LDL. That's the ones that, you know it, gosh. But the thing is, he needs to make money giving talks about these things so he can have this lifestyle. I mean, that's, well. So, but you see, this is my lifestyle, right? I mean, this was this last week. I mean, I bicycle to work every day, 20 plus kilometers, and I don't know, it's not very fancy, right? I don't know. I could have taken my wife's BMW convertible over there, but I usually let it sit there, right? Because it's much nicer to bike. You got it, Kosh? Whereas what Kosh he likes, that's a different lifestyle. So here it's, look, just try to look at his eyes, right? I mean, look. That's the car he really, really likes to buy. The thing is, you don't give enough talks to be able to do that, Kosh. So he couldn't buy this one, so he had to stay with this very much simpler car, a Maserati, right? But then at least he could afford to put the nameplate, K100 Ray, right? So that's all he's driving around in these days, right? And of course, I mean, you saw that all these, here are the different ones from the European Prevention Dyslipidemia Guidelines, and I mean, just these. I mean, statins, ezetimibe, and PCSK9 inhibitors, we can reduce LDL by 85%. We don't need more than that. That's plenty. So it's there. I mean, and we have all these here, even the ones with the very highest risk from the European Society of Cardiology, less than 1.4 millimolar, 55 milligram. You can easily achieve that with these three drugs. You don't need more. But of course, then, how can you keep giving these talks across? I can see that's a problem. Yeah. So this is just my simplified. I showed already today, but I mean, the problem is, of course, in the beginning that it was fatty food and LDL and atherosclerosis, but then came also these remnants that equally drives cholesterol deposition in the atherosclerotic plaques, and maybe the triglycerides lead to inflammation and plaque rupture, and then eventually these two diseases. And then we have the Lp(a) that maybe because of plaque rupture interferes with fibrinolysis, and therefore we'll have more severe myocardial infarction and strokes. So you're fully right. That's what I like. That's these two. And here's here just what's normal. I mean, LDL cholesterol. When I was a young doctor, this is the distribution of LDL cholesterol in the Danish population, and we started with the very high ones, and then came the statin trials, 4S trials, and high-intensive statin, ezetimibe, PCSK9 inhibitors, and we can bring the levels down to what is in newborns these days. So it's there. Whereas if you look at, for example, remnant cholesterol, it could also be Lp(a). We don't have the drugs yet. So there's so much more to go for there these days. So there's also this concept, but I fully accept it. It's fine. The lower the better. It's from this ES consensus paper some years back, putting a line for randomized controlled trials, prospective cohort studies, and Mendelian randomization. On the x-axis, showing how much you reduce LDL cholesterol, and then on the y-axis, how much you then reduce cardiovascular disease risk in respectively randomized trials just running for 5 years, in prospective cohort studies for 12 years, and the Mendelian randomization, which is basically lifelong. And so if you reduce it by 1 millimolar, 39 milligram per deciliter, that's, if you do it lifelong, you can actually halve coronary heart disease. And if you do it for 2 millimoles or 77 milligram per deciliter, you can almost eliminate it. That's all you need to do, right? It's just bring it down for a lifetime. And then there's also this other concept, which is also fantastic because we have so many patients that don't do these sensible things. I mean, bicycle to work and treat LDL very early on, right? Stuff like that. And so here, the concept here is just on the x-axis, time to after acute coronary syndrome. If we have a patient that start with 3 millimoles per liter, for example, 116 milligram per deciliter, then a lot of patients, they have the red curve. They start with some sort of statin, and then after a while, they Google, and then they have all this about side effects, and then they don't take it. And there's 70%, the doctor give them just one sort of like medium strength statin, maybe bring it a little bit down, and they just stay there. And the guideline is the yellow one, of course. It's meant that you titrate it up, so you bring it way down to 1 millimole or 39 milligram per deciliter. But you could also, if you give full dose in the beginning, at least high-intensive statin and ezetimibe, you could bring it down. That's what you should do, right? So so I understand all these concepts, and people don't do it and things, but you can talk about that course instead of just all this implementation stuff, right? So here's the statins, right? I mean, the effect compared to the side effects is fantastic. Half of LDL, halving ACVD, 20% reduction in mortality. And we talk about somebody that is already with a lot of atherosclerosis. The ezetimibe is on top of statin, additional LDL, additional ACVD reduction. It's fantastic. And the same with PCSK9 inhibitors, and no side effect for practical purposes. 50 to 60% LDL cholesterol reduction on top of statin, 15% ACVD on top of it. And of course, there's even the potential added benefits of LDL lowering. We don't know for sure, but maybe, yeah. And so this is what you want to talk about, Kosh. Just do that. Give a lot of talk and convince people about it. We need better use of current LDL lowering drugs, not more drugs. And so I use a case example just to illustrate for you what I mean. So this is a guy from Denmark. He took a statin daily from his 50th year's birthday. That was so I thought, well, that's the way to do it. Slightly elevated LDL cholesterol, no cardiovascular disease, no family history, no smoking, no other risk factors. And the person, the case had never had a side effect. Just ignored all the Google stuff about side effects. Started with 40 milligrams simvastatin, then 80 milligrams simvastatin, and then 80 milligrams atorvastatin for at least the last 10 years or something. And this is his values 14 days ago, yeah. So it's no diabetes, right? And that's a low HDL cholesterol. But the reason why the HDL cholesterol is low, that's because LDL is quite low, 1.8, and non-HDL 1.23. Remnant cholesterol, half a millimole. Total plasma cholesterol, 3.3 millimole. And I also have a quite nice Lp(a), right? So, if many people did that, you did that to your patients, then what's the problem? There's no problem, right? And but if you have a lifestyle that requires a lot of extra money, right? So it's then you have to think other ways to go about it. How can you do cost? I can see there's a problem here, right? So I made this slide a long time ago, 2011. If you listened, you would have understood exactly what I meant. There was just the hall full like this, full of cardiologists. But LDL cholesterol, that's really a salt thing. It's like a huge cruise ship. That's the ones you like to go with your wife. I think that's the type of stuff you go. And back then, already in 2011, the problem was Lp(a), but it's pretty solid evidence. But we still need the randomized trials, and then HDL, of course. Well, when we gave these talks on genetics back then, people didn't like us very much, right? Because that was the top of all the HDL cholesterol lowering trials. And then already back then, it's 14 years ago, I said that's the future. Remnant cholesterol, that's what you should go for. And so here I put the blue line is 2011, where I had that slide first time with HDL going down, a bit like Titanic. And then ever since that, Kos has been talking about LDL cholesterol. And even a bit after, when HDL went down after the blue line, I met him give talks about HDL and how important it was and reverse cholesterol transport. I said, you can't possibly believe in that. Why do you stand and say something like that? We kept doing it for a while. Now we talk about LDL all the time. So, but I do understand it. It's if you want to keep this lifestyle, you need to make money. I do understand that. That's fine. But it looks nice. That's Kos's wonderful wife, Claire, and they like to go nice places. Not like me sitting out at a mountain in Ethiopia and being almost eaten up by a hyena or something. But that's it.
So, with these unforgettable presentations, the first round is over. And now we have the rebuttal round. Please, Kosh, floor is yours. And then after both presenters have now 2 minutes for the rebuttal, and then we will vote. Okay.
So we basically, when we were talking about this, like I said, I referred to him as, he's more like Loki than either of the other two gods I was talking about. He said, you know what, why don't you go first? I was like, okay, fine, you're the president, I'll go first. And then I get this, could you send me some photos of you, on holiday next to a fast car and stuff like that? So at that point, I hadn't actually prepared my talk. I was thinking about logical arguments. So I then had to spend the next 24 hours trying to basically find various images that I had to put together. But I knew he was going to talk exactly about remnant cholesterol and LPN. And of course, all of these are important. Our biggest problem is LDL, if we use things correctly, would be a done deal, except for homozygous FH, where it is not a done deal. But for everybody else, the reality is our patients and the complexity of our health systems, that triangle between physician awareness, patient acceptability, adherence, how we implement it, and access, that is a big limitation of population health. And that is why we still need to search for things that are better tolerated, acceptable, cheap, and accessible. And then, in addition to that, remnant cholesterol and LPA are also very, very important, as you well know. So, thank you.
Honestly, I don't have a lot of rebuttal, but maybe just talking to all of you, it's like I just showed the example of myself. It's, try to do whatever you can in your country and talking with media about just having as many people as possible have a high-intensity statin. This is the simple salt way of going forward. And I know it's tough sometimes, but sometimes you have to fight what's on Google and what's on the media. So I think that's the important thing to do. I can tell you, I don't know if Erkin is here from Kyrgyzstan. He invited me once to a cardiology society in Kyrgyzstan, which is next to China, former Soviet Republic. And two of his colleagues, they took me a day up in the mountains and drove me around up there. And the driver was an old cardiologist. He didn't speak any English, like almost most people in Kyrgyzstan. They speak Russian or Kyrgyz. And then sitting in the back with a young doctor who spoke English. And then we sat there for a long time. Kyrgyzstan is beautiful. There's all these mountains. And then he suddenly says to me, do you believe in that statin intolerance? Because I've never seen any. Hasn't seen any, because they don't have access to English Google, right? There's nothing there, right? So, and then say, no, I don't actually believe much in it, except for this 1 in 1,000. And then I said, let's ask your colleague up front who's driving the car that speaks only Russian and Kyrgyz. And I said, ask him how many patients with statin intolerance have he ever seen? And he was sitting there driving the car. 5. And then I asked him, so how many patients roughly has he seen in his cardiology career? Then he said, more than 5,000. So this is what it was. 1 in 1,000. That's the number we have from the randomized trials. So I think let's fight that, and then let's get LDL down as much as possible for these fantastic drugs that's called statins. And some of you believe there's a lot of side effects because the patients come and complain. I understand that, but that's the easy way forward. And then, of course, remnants Lp(a), let's do that. They all 3 needs to come down. And have a nice evening. Thank you so much for being here.
Yes, thank you. They were really unforgettable presentations. And can we turn on the lights right now to see the... Okay, thank you. And it's time to vote. What you think, of course, on a scientific base, evidence-based. Well, if you believe in that LDL is a solved problem, as Borges said, please raise your hands.
One of those is your wife as well, the other one's your daughter.
Yeah, that's right.
So let's say the other words. And if you believe in that LDL is not yet solved, please raise your hands. So, thank you. And of course, we have a long way to go. We have new agents, new drugs, but we still have to implement the guidelines to reach the targets. Thanks for your presentations. They were really excellent and unforgettable. Thank you.